I'm going to reflect on what I heard this morning from the three speakers, Nigel Edwards, Sam Jones and Ian Bullock, in the course of what I'm going to talk you through. It's labelled Understanding Patient Demand, but you could label it Understanding Person Demand. It means the same thing. What we do too much of in healthcare, and healthcare in the round, so for me, it's as much about understanding anyone in a GP practice as it is in an acute setting, as it is in a nursing home, or is it, even if it is in their own home, as opposed to labelling people. So I'm going to do 5 things, hopefully. I'm going to outline a bit of context and convention. So what problems do we face? There's going to be a particular focus on the NHS, because that's where I've worked in, but there will be overtures, I'm sure, to the continent. I'm then going to outline the alternative approach, which is what I call understanding patient demand. I'm going to give an example from planned care of when things go wrong and why they go wrong, and how predictable that is, and the answer is very. And then I'm going to outline and provide an answer to what was talked about today as badge delivery, how you do intelligent improvement. And I'm not going to use the word or the phrase multidisciplinary team working. And then I'm going to conclude. Okay? A bit of context first. These slides say it all. We have record hospital deficits in the NHS. It's around about £2.5 billion worth of deficits across, and that's not a forecast figure, that's an actual figure pretty much now. And we've been on that trajectory for some time. Experts tell us that patients could suffer as a consequence of rising deficits and longer waiting lists. Absolutely. But what we need to understand is why this is happening. And the usual scapegoats that are always trotted out when we hear this story, and this has been happening and building up for years and years, and we have to understand why this is happening, is the classic line, rising demand. More and more people using more and more services in primary, community, acute, social care, and we just can't cope. As a consequence, we have 2 belief systems, and there's an error on this slide, so I apologise for that. The hospital belief is that rising demand means we get more financial deficits, which is that previous slide, £2.5 billion. In the UK, over the last 30 years, we made a conscious decision to split the providing of healthcare services between people that do stuff, hospitals, etc., and community trusts, and people that hold budgets and pay for them, and they're called commissioners. And rising demand in the commissioner landscape is referred to as overperformance, okay? Every year, and some of you are smiling because you know this, don't you? Every year, we come together in almost like a reverse Dutch auction, and the provider and which is mostly the acute, and the commissioner will have a bit of turf warfare for first months of the financial year to say, well, last year you did this amount of activity for this amount of cost, and that was too much. So we need to reduce that, and I want you to do less activity for less cost. And the provider will say, no, that's not possible. You don't understand the business. And this will spend months doing. And then we'll write things into a contract, and then within a matter of weeks, everything's going wrong. Now, this happens every year, and I know some of you are smiling because this is what we do. It's absolute madness. Why? Because we've dehumanised healthcare. We've decoupled it from why we have healthcare in the first place. The consequence is that we try to manage activity, and these are actual slides taken from a healthcare locality in the southeast. I'm not going to name which one. So if your obsession is on reducing activity, and you enshrine it in your cost improvement programs every year and your quality improvement and productive schemes, which are called QIPs, then you do some stuff such as this, which is really, it's an SPC chart with its lower and upper control limits, but it's based on activity. My challenge with all of this is it doesn't help you one bit in trying to improve, never mind understand your problems. So when we've exhausted what I call activity analysis, which is to try and understand why we've got more activity than we had in the plan, we then seek to go and benchmark and follow best practice. And these are slides on A&E. So they're just 3 different comparative providers against the 4-hour target that we have in the UK, which means it's mistakenly referred to as a quality and performance measure. But what it is really an activity measure that we have to do something to you in the first 4 hours of you coming to an accident, an emergency, or an emergency department. Okay? It's not the same thing. An activity measure is not the same thing as a quality performance indicator. But that never works either. Okay? Activity goes up and up and up. I call this activity obsession disorder. Yeah? Like it? Because this is what we do, whether we're a vanguard pilot or not, in every single healthcare economy every year. And it's a bit like, and I can say this because my late father had this condition and it ultimately killed him, it's a bit like organisational Alzheimer's. You do the same thing and you expect a different result. It's like the goldfish, and it never works. So we've got to change tack and adopt a different perspective. As a consequence of this activity obsession disorder, we do a number of things. And on the left-hand side, they're listed all the various improvement approaches. I've already talked about activity benchmarking. Keep your mind's eye on patient flow. Nigel mentioned patient flow programs earlier, and I'm going to come back to that later. Because the worst thing you should do is focus initially on patient flow in any healthcare economy, because they never work. I've never been to one healthcare system that can point to me to a patient flow program that is actually working. I call it rolling the dice. It's reductionism, because you're hoping for 2 6s every time, and it never comes. What we've got to do instead is bring back healthcare to the reason why we have it, and I call it humanising healthcare. And for me, that's understanding patient or person demand as the first point of call. What do I mean by demand? Well, demand is person-shaped, as it says on the slide. It comprises the requests that individual people make on services over any period of time. Now, that could be 1 day, that could be 1 week, that could be 1 month, that could be 1 year, that could be multiple years, okay? It's about understanding what have we got to do from the point of view of you as a person. What problem or problems do we have to treat and or manage to give you a better life, or, if we can't do that, dignity in death? What we have at the moment in the NHS, and I'd be interested in your perspective as to whether you see this in other healthcare systems, I suspect it might be, is we have a perverse NHS convention at play, which has got to be changed, which is where we label people patients, and when you label someone a patient, or a bed blocker, or a frequent flyer, you've just dehumanised the whole problem, and dehumanised them in the process. And then we convert what we've got to do into coding mechanisms, which then forms the basis of activity. Remember, it's activity obsession disorder, and it's on the basis of activity that providers get paid. You see how we've distorted the purpose in doing so? Because when you think of it differently, another way of expressing this is what I call PAC, which is people, activity, costs. Activity and costs are lagging indicators. They're a consequence of what you do. Now, you might do that well, you might not, but we have to start with the big and the little P's to understand who are we doing activity to, how well are we doing it, because that'll tell us why it's costing what it is. And that's the way you get at changing tariff mechanisms and the like, and also regulation. Because if you do this, you come up with a different set and quite profound results. This is not Hamish Dibley's opinion now, because I've done this in several different trusts. Big tertiary teaching hospitals and small district generals, and it's the same everywhere. Rising demand, it's a myth. It's not happening. What's rising is activity on stable numbers of people or patients. Time series data, this is from one of the largest teaching hospitals globally. It happens to be based in this capital city. At the top, it tells you as a percentage term how many people use the hospital in any shape in any 1 year. And what you see everywhere is that it's a stable third. So when I heard today we need to focus on managing populations, no. There's 2/3 of the population that never use the acute hospital in any shape or form, okay? Every patient is a person, but not every person is a patient. You are not commissioning for populations. You're commissioning for people that use your services. Expressed in numerical terms, we see that the growth that there is is actually year on year just going up with population growth. In other words, it's manageable, okay? So that's the starting point. You go to most NHS providers, they wouldn't know how many patients they saw in a year because they obsess on activity. Well, activity only happens to people when they need help or treatment. How that breaks down, and this is important, this is a very, very high-level decomposition chart because you kind of need to know your customers, yeah? No matter what walk of life, it helps. I'm going to focus for this section of the presentation on A&E, or ED as it's sometimes called, okay? Which is, of those the 262 or 263,000, that's the hospital population, okay? This hospital thought it had a constituency population of 5 million. It then, when I said that can't be right, went back on a 3.5 million figure. And then when we challenged it again, they said, well, okay, it might be 1.3. Well, actually, when you do the analysis, and you can do this quite easily with a golden thread, NHS number, because the NHS knows 99.9% of its customer base if it wants to. Most retail establishments would be lucky to get away with 2/3, because, of course, if you pay by cash, you've got no footprint on you at all. Using that logic, in A&E or ED, they see about 40%. These are unique people every year, okay? And then how it breaks down is, well, we admit about 1/3, and we don't admit the rest, okay? So let's go. If we need to do something seriously in urgent care, and in many parts, the problems in urgent care are the reason why you've got problems in planned care with cancellations and longer waiting lists, let's understand a little bit more about the people that come in, how often they come in, and why they come in. And what you find is of that 100,000, really, really small numbers, and I call them the vital few, are causing disproportionate amounts of activity and cost year on year. I'm also going to challenge the Kaiser Permanente logic and thinking, because that's about 25, 30 years old. At the top of the apex of any acute trust, the job to be done is actually on really manageable numbers of patients, where there is, when you actually speak to them, talk to them, pull their case notes, understand them, as opposed to labelling them, a complete disconnect and weak association between what we commonly refer to as medical acuity, the Kaiser model, which is you manage complex case patients. You don't see that. You see a real weak association between medical acuity and consumption. What you see at the top are loads of people coming in repeatedly, and I'm talking 50, 60, 70, 80 times a year into A&E with social, psychological, emotional, environmental problems. And they boomerang. And they do this until you're about to see many of them die. Okay? And it's not a frail elderly problem. When you do this analysis, and you have to do this analysis to understand your business, you realise that 2/3 of those people, and it'll be the same in any hospital, aren't frail. Well, they're frail, but they're not frail elderly. All right? 2/3 to 3/4 will be under 65. Okay? You will have problems within certain cohorts of patients who are in the frail elderly category, but they are not the majority. What you find a lot is females in their 50s whose life's gone off the rails, but we met with a transactional medical response, so you're coming in 80 times a year. You'll be coming into the general practice a similar number of times because I've done this work there as well. So we spend a fortune of money on the same patients. In this particular trust, the top 20 offenders, if you want to use that label, were guys in their mid-30s to late 50s. And when you pull their notes and do the journey mapping, it's quite horrific. We don't help them. What we do is we say we ration care away when it comes to the support they need, and much of this is just about problem solving and empathising and actually building services around patients. But what we do is we standardise pathways against mythical patients. But we are then we've got a problem of non-standard patient meets standard pathway, and a mismatch ensues. So that's where the activity and the costs are generated. And by the way, when you do this as well, you find something profound, which is that £2.5 million or £1 billion worth of deficit that I spoke about earlier, when it's broken down into individual trusts, it's on the same numbers of patients. That is quite profound. They didn't know that. So to talk about the vital few as it refers to A&E or the urgent care system, this is a Pareto chart or a consumption chart over 1 year. So that's that figure of 100,000. So patient demand is predictable, stable, and repeatable. We've seen everyone who's coming in more than once, and even now, if you come into A&E more than once, that's really, really rare. Okay? If you're coming in more, 2, 3, 4 times, that's off the Richter scale. But it's uneven. Some patients, really small numbers, are consuming alarming levels. Here, it was 6,500. 20% of everything they were doing was on a really small number. And remember, base it back, their population was 260,000. Now I ask the humble question, do we know those people? Do we know what problems we've got to solve for those people? I'm afraid the answer is no, we don't, because we manage and obsess about activity. But it's that activity obsession that causes costs because we dehumanized our responses. So they're coming in a lot. We're then making them wait longer than the average Joe that has any involvement in A&E. And you see this in primary care too. It's common for these people to keep ricocheting and boomeranging in their general practices 50, 60, 70 times and be made to wait longer between appointments. Why is that happening? You know, if you're coming in 80 times a year, the problem isn't yours. The problem is, what are we doing that's any different on the 80th occasion than when you came in on the 8th? And when you do this type of analysis, you find out that nothing's changed. Okay? It's the obsession that we have. Then you find that really small numbers, again, of the vital few, are behind all the performance problems. And this is true. Empirically, this is what you see. It's not me telling a story. This is the data telling you what you've got to do. 50% of all the A&E breaches. Now, the A&E target's a bad target, okay? So one of the first things I'd want to do if I was a chief exec is get special admission from people like Sam to do away with the 4-hour target. It's a bad measure, okay? Some of the things that Nigel talked about, putting the expert at the front door, yeah, that's good. You need to do that because that will stop the wrong people coming through, but it won't stop them keep them coming 80 times a year. That's a different problem. So they're behind large numbers of breaches. They're then disproportionately more likely to get admitted. And when they get admitted, it's in short stay units, assessment units, observation units behind A&E because of the pressure of the 4-hour target. Now that's actually been listed in official guidance as good practice to do, but it's not. It's very bad practice, and it's causing all the mayhem. And the ultimate is, of course, where these people go. They're 10 times more likely to die in hospital, and in every hospital you'll find that they're around about a third behind all the mortality statistics. So that when they do literally disappear off the radar, it's because they're dying or they're dead in hospital. And then we have to ask the human question, did we do a good job? Did we understand them? Did we help solve their problems? Did we help get the lady in her 50s or the guy in his 40s whose life's gone off the rails, did we get them back on the rails with stabilisers? Did we keep those stabilisers on, or did we refer you away and then we lost sight of you until you're back round the next day? Because this is what you see. So that's urgent care. Mind's eye on patient flow programs, which Nigel talked about. When you link activity data via human unique patients with financial data, and this is all available in these trusts, they choose not to do it, or they don't know how to, you find really, really alarming things, that you can have the world's greatest flow program, but it will never work because of the way we construct the tariff system and payment mechanisms. That's 16 typologies, you just saw the top 5. Okay, so that's everyone you see in urgent care or planned care put together. When you do this analysis, and again, this is just playing back what they should already know that's at their disposal, you find that actually we only make money on you. Remember, this is accounting rules, so a minus is a plus, all right? We only make money on you if you have planned care activity. If you use a lot of urgent care, we're running big losses on you. And if you have a lot of both, we're running really, really big losses, and they're the top 5 over there. We then, after we've understood patients or people and what problems we've got to do, need to have a serious, mature conversation around what's equitable and fair to pay to solve your problems, as opposed to, this piece of activity, you're going to get that much. Again, dehumanise. Now, Mr. Mars Bar Man, this is planned care. What you see in plan care is interesting. And then I've done this in other hospitals as well, is that, again, about 3/4 of everyone who first appears in plan care at some point in time is going to tip. And they tip into urgent care. He was called Mr. Mars Bar Man because he had 3 problems going on with his world. He had prostate cancer, he needed a triple heart bypass operation, but before he had that done, he needed to have his wisdom tooth extracted. And this is where the problems ensue. 3 hospitals were engaged in this, doing different things. The hospital that needed to take his wisdom teeth out lost his referral. Okay, he then spent months, and I'm talking 7.5 months, trying to progress chase as to what you're doing. He was seen countless times in outpatients land. No one consultant saw him continuously. The hospital had to dial down the prostate cancer medication because, of course, you can't do that if you're about to have a big heart operation, but no one saw fit to communicate with them, so they ended up writing to the patient, do you know what's happening? He got more and more stressed, as did his family. It came to its usual conclusion. 7.5 months in, Monday night, he suffers from shortness of breath, can't breathe, an ambulance gets called, he will tip, and he did tip. He spent 2 weeks in a cardiothoracic unit after going through A&E. We didn't do anything to him other than monitor him. And remember, we're paying £500-600 a night on a bed. He then gets transferred to the specialist hospital who were going to operate on his heart after the 4th different ENT maxillofacial consultant said, you don't need your teeth out at all, you just go and get your heart done. But that took 7.5 months of faffing about. He then got transferred to the hospital to operate on his heart at the very week that consultant was then taking a week of leave. So he then spent another week in the cardiothoracic unit of that specialist trust. He got discharged the week after because he wasn't a priority case. And his operation was rescheduled to take place on day 2 of the junior doctor strike. So everybody knew that wasn't going to happen. And then 2 days later, he got a letter saying that had been cancelled and put back too. He actually managed to get his heart sorted out. But can you see one person creates a whole lot of activity and a whole lot of cost because we haven't understood them and the processes and the systems are broken because the focus is wrong, okay? We don't have the operational research or operational performance improvement mindset that we need in order to run efficient services. If you want to know more about his case, it was broadcast on the BBC World at 1 back in April, and it's on the website, 14th of April. That's a genuine story. Now, I know, from having spoken to other cardiologists, that this happens a lot, everywhere. And he's going to be behind the causes of the costs, and it won't just be cardiology that it's applying to or affecting. Bit on improvement now, and I will wrap up, I promise. On the left-hand side, I'm going to come back to what someone said today, because the focus was all about deliver. We've got to focus on delivery. But in my world, you often find that because people don't know how to understand their problems and don't know how to improve, we leave delivery to project initiation documents or the whole rigmarole around project management office malarkey and documentation. So we write business cases until the nth degree. We write project initiation documents. We think about work streams against standard pathways without understanding that actually we've got loads of non-standard patients which will never meet a standard pathway. So we do the activity analysis. All of that never works. PMO never works. PMO isn't about actually changing anything in the real world. It's just about reporting to talk and talking to report in meetings, what may be called MDTs or may not be. What I'm about is let's understand the patient base in its entirety, but let's understand what problems we've got to solve for different types of people. Let's focus on the vital few. Improvement is about prototyping around cohorts of patients, okay? Not standard pathways. There's a big difference. And you have to customize care for small numbers in order to learn how to improve and improve how to learn. Expressed another way, you need clarity of purpose. What do we have to do for you? What problems have we got to solve for you? Okay, and you'll find that the crossover between the Mr. Mars Bar Man of this world, and by the way, he was referred to as a Mars Bar Man by an ENT consultant who tried to explain to him he didn't fit in to a standard pathway. He was like a wonky Mars bar on a production line. So that's why he had to be taken off and put to the back. He found that quite distressing, as you might think. What problem did we have to solve for him? What problem do we have to solve for someone rocking up to A&E 80 times a year because they're not coping with their life? It's gone off the rails. Then we have to think about real-time, intelligent performance metrics, not average length of stay, because when you get into these vital few cases, we're talking about an average of an average, which is no number at all. It's about end-to-end times, first-time resolution. Are you coming back round repeatedly? And you find in every acute that 60% of everyone who's been in year one is coming back in year two. Why? And then you have to get into the real work, which is about designing the prototype on small numbers of people, at the front door and the back door, or in the waiting time door. And then you have control groups in order to understand how well you're doing in year. By the way, you don't need to be a vanguard to do this stuff, and you can rebadge any one of your CRIPs or SIPs to do it. It just requires leadership and a bit of vision. So by way of conclusion, the problems are in the front door and the back door. Where you do have a frail elderly problem in healthcare is in the back door, but even then it will be really small numbers of frail elderly people causing all the problems. In the front door, the challenge is different. But as a consequence of the activity obsession disorder that I talked about, this knocks into cancellations. We have to put you back, Mr. Miles, my man, because we can't cope with the panic that's happening in the front door. That then knocks on to longer waiting times. And so then the wheeze is, okay, we'll pay the independent sector and the private sector loads of money to backlog bust our waiting times, and it will be exactly the same NHS consultants doing the work on a weekend or an evening when we created that backlog in the first place. And then that leads to reduced income. Or if you're a CCG, you're paying out more than you said you were going to or you've got. Transformation starts with understanding the who, why, what, where, and when of person demand, and improvement is about redesigning services and systems around cohorts of patients, not standard pathways. If we really want to achieve the holy grail of healthcare, I would strongly advise us to change our perspective on what matters. Thank you very much for your time.